equally on a very controversial subject by none other than Dr. Martin Leon. He will be speaking to us on multivessel angioplasty and culprit vessel angioplasty. And Dr. Martin Leon, of course, I don't have to introduce him, you all know him. And Martin Leon, please.
Thank you very much. Well, it's my second day here, and I think I've adjusted reasonably well to the time difference and to the weather. And I was told by the organizers that I would have some liberty to extend my discussion in different directions, and that's what I'm about to do. So I do want to share some of my opinions about CAD management and talk a little bit about the roles of medical therapy, bypass surgery, and PCI. And I'll tell you what changed my mind. These are my disclosures. I'm a non-paid consultant for many of the medical companies that you're familiar with, Abbott, Boston Scientific, and Medtronic. But what changed my mind was this. I got on the plane, Emirates, and I picked up the Newsweek, and this was this week's Newsweek in the United States. And it's a little bit hard for you to see it, but it talks about medical care in the United States. And they say stents are recommended if you had a heart attack less than 24 hours ago, but not if you are stable and have no more than mild chest pain. Many of the 500,000 elective angioplasties, this is in the US, costing $50,000 each, performed every year, are done on patients who could benefit more from drugs, exercise, and healthy eating. And they say in the middle of the article that patients should start saying no to the physicians if they're being over-treated by cardiologists or by orthopedists or by neurologists. So it's a very interesting article, but this is what we face in the United States. And it's an interesting dilemma that I think is worthy of discussion. Certainly, we're dealing in a guideline-driven era, and these are the most recent guidelines from ESC on how to manage patients who have coronary disease, comparing bypass surgery versus PCI. And you can see there's a lot of green in the bypass group and not a lot of green, which is a Class 1 indication in the PCI group. Most recently in the United States, apart from guidelines that are done by committees in a very careful way, we have something new called appropriateness criteria. And again, these are the most recent appropriateness criteria published in JACC in 2009 for patients with coronary disease, PCI versus CABG. For CABG, you see all green. For PCI, you don't really see very much green. You see a lot of things that are inappropriate and a lot of things that are undecided. So we're facing a situation now where PCI, particularly stents and treating patients with coronary disease in the United States, is really being attacked by many different sources. This has turned into a public relations nightmare. As I mentioned yesterday on the Dr. Oz show, stents are being characterized as dangerous and the most unnecessary heart procedure that's ever been done. This is not based upon data. This is based upon a variety of other, I think, publicity-driven and confusing and confusion amongst physicians and certainly many of the practitioners. And in many respects, I think the cardiologists are their worst enemy, because a lot of the attacks are driven by other non-invasive cardiologists who frankly think that intervention is over-practiced. And it's an interesting concept for us to understand, because we need to communicate with the larger cardiovascular medical community as we manage patients. So let's talk about the indications for PCI. Certainly for STEMI, no one seems to argue, this is a 23 randomized trial meta-analysis involving almost 8,000 patients, that PCI, and now stents, and you can argue bare metal versus drug-eluting stents, are the treatment of choice versus fibrinolytic therapy. A 2% absolute difference in mortality. Certainly timing is critical, so we emphasize the timing, and we're very conscious of what's called daughter balloon time in the United States in terms of how to apply PCI in patients with AMI. So this is a clear indication where for the first time PCI reduces mortality in a subset of patients with coronary disease, and irrespective of what kind of fibrinolytic therapy you use, even when in the risk here registry, when you talk about pre-hospital thrombolysis, still there was a significant difference in cumulative mortality favoring PCI, largely with stents, in this very large, over 20,000 patient registry in Sweden. So for AMI, no question. We're talking about class 1 indications, certainly within the first 12 hours. Even between 12 and 24 hours, it's a class 2A level of evidence C indication, so we use liberally PCI as the standard treatment for patients for AMI. The second subset is ACS, and this segment is dedicated to AMI-ACS. The preponderance of data, again, 9 randomized trials over 10,000 patients, suggests that an invasive versus a conservative strategy is preferred in managing patients with acute coronary syndromes, non-STEMIs, with an 18% reduction in the composite endpoint of death or MI. And certainly, again, class 1 indications, 1B, 1A, depending upon certain subsets within the ACS category. There's almost no downside to going faster rather than slower with an invasive first strategy for acute coronary syndromes. And certainly, we generally take patients who need to go to the lab. They have refractory symptoms, they have rising enzymes, they have either heart failure or LV dysfunction, and they have other parameters of high risk. So we've now settled the issue for about half of the patients that we do PCI on, STEMIs and acute coronary syndromes. So the other half are patients with so-called stable coronary disease, or stable angina, which is a term which I think needs to be revised. If we look at patients with so-called stable angina, there's a wide range of morbidity and mortality. Perhaps some of the best studies have been done using nuclear imaging to actually quantitatively measure the percent of ischemic myocardium. And you can see if you have a higher amount of ischemic myocardium at risk, your cardiac death rate, and this is a relatively short follow-up period, is much, much higher. So identifying those patients with ischemia, significant ischemia at risk, classifies a so-called stable patient as being at higher risk unless something is done. And this is patients treated with medical therapy. In the COURAGE trial, in the nuclear substudy from the COURAGE trial, if you look at the rates of death or MI by residual ischemia, looking at patients who had myocardial perfusion studies, you can again see if you had more than 10% region of risk, ischemia, you had a dramatic 40% death or MI in the medical therapy group. So clearly, ischemia is an important component in making a decision about what should be done, revascularization versus medical therapy. So, what are the data? Medical therapy versus PCI. I think many of the arguments about medical therapy are a little bit foolish to me because all patients with coronary disease, stable or otherwise, certainly should be on optimal medical therapy. So optimal medical therapy is not something you simply apply to patients who don't get revascularization. It should be applied to all patients. So we're talking about appropriate antiplatelet agents, we're talking about controlling risk factors, we're talking about statins and other things. The COURAGE trial certainly got a lot of press in the United States and worldwide. The results were overall negative. We could spend a lot of time talking about some of the flaws and some of the issues associated with COURAGE. It was mentioned yesterday. There's a new trial called the ischemia trial, which I think will address many of those issues. And it'll take 7 years to enroll, follow up, and analyze those data. So as physicians, we have to make judgments without the benefit of some of these mega trials that take a long time to do. But even within COURAGE, if you look at the data, the rates of death or MI were clearly related to ischemia reduction. If you can reduce the ischemic burden, there was a twofold difference in death or MI. And if you look at PCI versus just optimal medical therapy, there was also a very significant difference in which of these two strategies reduce ischemic burden, with a significant difference favoring PCI. So if you have patients that have significant myocardium at risk, PCI has a much greater likelihood than optimal medical therapy in reducing ischemia. And once again, from COURAGE, if you look at ischemia reduction of greater than 5% of the myocardium at risk, there's again a twofold difference favoring PCI versus medical therapy. And going back to that earlier work done at Cedars in California, seeing this escalating risk associated with ischemic burden in those patients who had revascularization, either CABG or PCI, there was a dramatic reversal of the risk. So to me, identifying ischemic burden becomes a critical issue. It's not whether you treat patients medically, it's deciding which patients can be treated with medical therapy alone. And if you look at COURAGE, only 1/3 of the patients that were enrolled in that study had significant ischemia at baseline. If you look at another smaller randomized trial, the SWISSY-2 study, where ischemia, significant ischemia, was a qualifier. You had to have it to get into the study. Suddenly PCI was dramatically better than drug therapy with a marked difference in death and MI, which tends to corroborate this hypothesis that patients with ischemia do better with revascularization, either PCI or CABG, versus optimal medical therapy. So what about bypass versus PCI? We've been fighting with our cardiac surgical colleagues now for 3 decades about which patients should be treated with which technique. The data with bare metal stents and bypass surgery, there are many studies, many meta-analysis, the most recent of which indicates that for hard endpoints with bare metal stents, the rates are about the same. If you look at death, stroke, MI, the heart events, it's about the same, MI and CABG. But repeat revascularization, very different, favoring CABG. So that really the discussion is to what extent you value repeat revascularization as a necessary component of a composite endpoint. The SYNTAX trial you'll hear about during this meeting, you've heard, I'm certain before, is I think the most definitive study thus far. It's a large study, but it really is an unrealistic study. Look at the patients enrolled in SYNTAX. We're talking about 3.6 lesions per patient, 4.6 average number of stents. The mean stent length implanted was 86 millimeters. 1/3 of the patients had over 100 millimeters of stents. These were really patients with extreme anatomic severity of coronary disease, which many patients really don't treat with sole PCI. But even in that study, if you look at the hard endpoints of death, CVA, MI, out to 3 years now, there's no significant difference. A slight late trend favoring surgery, but the hard endpoints are the same. Yes, there's a difference in revascularization, even with the Taxus drug-eluting stent, and that drives the composite endpoint of MACE, which included revascularization, so that yes, it's statistically significant, and that's an important observation, but you have to look beyond those overall data in this clinical trial. Much of the late effects in that study were driven by the relatively high frequency of late stent thrombosis associated with Taxus, which is a stent not used very much anymore, and during this study, most of the patients did not receive dual antiplatelet therapy for a particularly long duration after the first year. We did learn from SYNTAX that not only ischemia scoring, as we've suggested in the last few minutes, but anatomic scoring of lesion severity and anatomic burden of disease is an important component and risk factor which helps you to make decisions as clinicians. So looking at something like the SYNTAX score, which is a way of grading these lesions, is something that many people do routinely. And if we break up the data, now looking at 3-vessel disease according to SYNTAX score, in patients with less significant anatomic disease, it's about the same. This is the overall MACE rates at 3 years. But as you get higher SYNTAX scores, the upper 2 terciles in the 3-vessel disease group, you see these curves spreading, clearly favoring CABG, even for some of the hard endpoints, including death and MI and stroke. Different when you look at left main disease, where actually in the lower tercile, PCI did better than CABG, and even in the middle tercile, there was an almost significant difference in mortality favoring PCI versus CABG in these left main patients. So we learned a lot. Patients that had severe anatomic severity of disease with 3-vessel coronary disease, probably CABG is better, probably. But left main disease in the lower 2 terciles is seen to be at least equivalent to CABG, and maybe PCI is an alternative and maybe even a superior alternative. And that's being tested in another study that we're about to start, the EXCEL trial. We also have to consider the completeness of revascularization, and we have to, in the cath lab, make a better assessment of ischemia. From the New York State PCI database, you can see here that clearly, if you do PCI and you don't achieve reasonably complete revascularization, your outcomes are not going to be as good. So if you have a philosophy of only doing culprit lesion angioplasty, you will not have the same outcomes as CABG in patients with stable angina. And from the FAME trial and now many other studies that I think will corroborate this, if you do invasive ischemia testing, even using less stents, well, certainly you will use less stents, the overall outcomes, the MACE-free survival is better. So we now in the United States certainly are looking much more closely at physiologic testing in patients with stable angina. And it's not enough just to look at the angiogram, because you can see here in this very nice breakdown of the FAME patients that if you have a 50 to 70% lesion by visual assessment, only 35% of the time is that going to be significantly ischemic. So you really do, unless you have severe anatomic obstruction, have to consider invasive physiologic testing in order to make decisions about the appropriateness of revascularization, and that is done on a lesion basis. So what I'm saying is that there's been a great deal of confusion. It's certainly expressed best in the press. This is from the Wall Street Journal in February of 2010, where February 11th, they said stents were terrible. They're being overused. The market is going to go down. Courage is going to crash the stent market. The next day, Bill Clinton has chest pain, comes to Columbia. We put in 2 stents, and now stents are wonderful. So I don't think that the lay press should determine what we as physicians do. I think we have to have a rational approach to treating coronary disease, that optimal medical therapy should be applied in all patients, that the need and urgency for revascularization therapy, either PCI or CABG, is proportional to the acuity level of the clinical syndromes, greatest for STEMI, then ACS, and least for stable angina. Treatment decisions for stable angina requires a very sensible, case-based, individualized approach which integrates the severity of symptoms and the response to medical therapy, the presence and magnitude of inducible ischemia, either non-invasive or physiologic in the lab, and the presence, location, and severity of angiographic stenoses. That optimal PCI, which means pretty much complete revascularization, is preferred in patients with moderate or severe ischemic burden, poorly controlled symptoms, and/or very high-risk anatomy. There are many caveats. Angiography is usually, not always, but usually required as a component of this decision-making process. In the modern era, ischemia assessment on a lesion basis may be required using invasive tests, as we said, FFR, to discriminate many of these so-called intermediate lesions. Patients should actively participate in these therapy decisions, and PCI should be considered as an alternative to reduce angina if medical therapy is poorly tolerated or if important lifestyle limitations remain. So once again, the art of medicine requires the judicious application of both evidence-based medicine and clinical judgment for each case-based scenario. Thank you very much.
Dr. Leon, what is your take on culprit lesion angioplasty versus multivessel angioplasty in acute MI? What's your take on culprit lesion angioplasty versus multivessel angioplasty in acute MI?
Okay, so my feeling is that certainly we treat culprit lesion angioplasty in acute MI. If the second or third vessel has a critical lesion, which we think is ischemia producing, or if the patient has instability or evidence of heart failure or reduced LV function, we would go back and we would treat the second and/or third lesion prior to discharge. Otherwise, we would evaluate those patients electively after discharge, and based upon ischemia and symptoms and other things, make a decision about treating the other lesions.
I would like to ask you, what is your take on DES in acute MI?
The best data, I think, in DES and acute MI were just presented, which is the Horizons data. And I think that there certainly is, and we've come up with risk algorithms in terms of restenosis from the Horizon data to characterize what patient subsets would most benefit from DES versus bare metal stents. In the United States, it's about a 50-50 split of bare metal stents versus DES. We tend to use DES when we know the patient, feel comfortable that they will comply with prolonged dual antiplatelet therapy, and the lesion complexity indicates that restenosis with bare metal stents will be sufficiently high that a DES is preferable. And that's about 1 in 2 cases.
Do you think optical tomography has a role?
I'm sorry?
Optical tomography. OCT.
OCT.
Lesion morphology and then finding the lesion morphology and then strategies.
We're still learning about OCT. We had a long meeting just last week to discuss the next series of studies on OCT. OCT is complementary to IVUS. We use a fair amount of IVUS in our laboratory, and I think we learn a lot about the lesion morphology, but understanding under what circumstances OCT should be used to try to make scientific decisions about improving angioplasty, I still think is up in the air. But it's very different than IVUS in terms of what we're learning. And many of the quantitative assessments from OCT still need to be validated in controlled clinical trials.
I think we must thank Dr. Martin-Leon for excellent presentation on multivessel revascularization. He cleared many of our doubts and clearly told us where to go for angioplasty, medical treatment and surgery. Obviously, he very clearly told that you have to not only angiography, but you need to have FFR and other diagnostic marker to find out ischemia before deciding revascularization. Thank you very much.